My name is. Good afternoon, everybody. My name is Ishaya Bitrus, and my topic is the anchor effect. Okay. So to optimize health subsidy design for long-term child health adherence, my community is the Gongi community in Maiduguri, Borno State. So the problem is being a clinical student, and while I was doing my clinical postings, observed that some organizations come and they start some programs where they fund the healthcare of maternal, they fund maternal and child healthcare. They start 2 years, 5 years, but after decline, you no longer see the women coming in for routine checks for their children. So that was why when I saw this opportunity, I was in this psychological setting for China to see if dependency ratios, family size, or other factors generally that influences the choices of these women that makes them choose to come or decide not to come. That's for those that don't come, and for those that come, what are the factors that influence those choices? So the questions, I used the hypothetical purchase task, but the questions were divided into two parts. The primary questions, how does the initial price anchor, that's from 0 to 15 naira to 1,000, influence a mother's subsequent willingness to pay for her child's healthcare service? The secondary part of the question, how do household factors, family size, education, if she has a job, community, and other things, how do they play in this anchoring effect? So the methodology, talk about that. So the methodology employed is structured survey consisting of three primary sections. The stated preference bidding. Participants were presented with a range of monthly subsidy costs from 0 to 70,000 naira in the survey form, and have to indicate their willingness to pay. And for this, we're looking to observe at which point does the drop happen. That sudden drop, or for the ceiling, how much are they willing to pay, and how far can they go with price? So then the second part, the perceived value assessment, asks questions that study the trade-off between quality and cost. And for 7% of the women stating that they are more likely to pay for high quality services despite high costs. But then there are other factors that hinders them from paying, which we'll get into later on. Um, and vulnerability, a qualitative scale. For the findings, this demographic curve compares the price sensitivity between two groups, and these groups are the small families and the large families. The small families are marked with blue, while the large families are marked with red. So you see that the large families at this point, there was a sharp drop in price at somewhere around 1,500. There was a sharp drop in their willingness to pay for healthcare for their children. But for the smaller families, it was consistent, and they were still willing to pay for a very up to 5,000. This can also be tied to the resources. When the resources is little and there's more people to cater for, the willingness to pay is going to drop. But when the resources is little, and then there are little mouths to feed, or there are little people to cater for, like 1 to 3 children, they can spare something since they already have the willingness to pay for it already, as stated earlier. Then my second curve plotted against employment, use the employed women and the unemployed women. So from here we can see the group A being the blue ones. There is a willingness to pay, a high willingness to pay at almost every point till somewhere around 1.5 also, where there was a switch. Also for the unemployed women too, there was a drop in price and there was no increase. After the drop from this point, they were not willing to pay again. It was kept going down, down. And this can also be tied to the resources. Since the employed women have more resources, they earn money, so they are willing to pay for a longer amount of, they are willing to pay more because they have it. As stated earlier, there is they have the willingness to pay, but some of them don't have the resources for that. So this group, the employed women, have the resources, so there is willingness to pay for the child health care. So for my conclusions, based on the synthesis of the community, I was able to come up with three conclusions for these presentations. The first one is the household burden as a barrier to care. As a barrier to care. This data from these women in Gungi confirms that the household dynamics, specifically family size, as number of children they have, are the strongest predictors of healthcare demand. While the community highly values maternal health, with 60.5% of respondents currently managing 1 to 3 children, the financial reality is that 84.2% of households find it very difficult or somewhat difficult to pay for non-free services. Consequently, as household size and pregnant parity increases, the demand curve becomes significantly more price elastic, making them the first to drop out of routine healthcare as cost rises. That's for the women with more children, household with more members. The second one, the optimal subsidy threshold. The data demonstrates a clear tipping point for community participation. Demand is most robust and stable between 0 and 500 per month. Beyond 1.5, there is a sharp increase. There's a sharp increase in the drop rate, as we could see. After 1.5, there's a sharp increase, and also for here, after this price point, there's a sharp decrease for, sorry, yes, below 1.5, these, okay, sorry, sharp increase in drop rates, particularly for large families and high parity mothers, that's mothers with small children and poor, and the unemployed mothers also, sorry, who must balance multiple compelling costs. Final recommendations: to maximize public health impact and ensure equity, the subsidized health program should be anchored at a price point below 1,500 naira a month. This ensures that the 52.6% of mothers with high parity over 3 pregnancies, as over 3 children, maintain this affordability while emphasizing high quality delivery. Providers can successfully anchor routine health seeking behavior across the entire community. If the price for healthcare is above 1.5 a month, is high likelihood that the mothers would stop coming for routine checks. But if it's between 0 and 1.5 a month, the women in Gonge community will continue coming back, as it's the ceiling of price they can go. That's how far they can go. Also, there is one thing I noticed also with the data. Significant finding of this study is that poverty does not equate to lack of appreciation for high quality, as a good number of them stated they are more likely to pay for high cost quality services than for low cost average quality ones. This suggests that families are willing to make financial sacrifices if they perceive a high quality of the service. So there's this further confirms the what I said earlier of what the data gave us earlier, that there is the women are willing to pay, but there is no resources. So I think that's the end of my presentation. Thank you.